I am here to, excuse me, introduce our next presenter for the session called Using the 4Ms to Organize Older Adult Care. So I'm here to introduce Julio Defillo-Draiby, who is the Director of Geriatric Education and Clinical Programs for the Department of Geriatrics and Palliative Care at Care New England. He is the lead geriatrician for the acute care for elders unit at Kent Hospital and assistant professor of medicine at the Warren Alpert Medical School at Brown University. His research focus includes the prevention of geriatric syndromes in hospital settings and the reduction of post-operative complications in higher risk older adults. He is passionate about teamwork and value-based care interventions. His recent publications and current research work examines the impact of geriatric co-management as a way to optimize care for older adults while decreasing overall costs. Welcome, Julio.
I'm assuming everyone can see this now, if Ms. Murphy can see it. Very
Yes.
good. All right, very good. So we'll start right now. So I'm going to try to talk about that framework that Ms. Murphy already touched base with. In a way that we can provide age-friendly care to any older adult in every point of care, or it could be even the one that we provide at home. The objective is to learn this framework, kind of an introduction of the framework, and then understand the importance of building a team to be able to take advantage of the framework. We have been using it for around 4 years here at Kent. It came full force in 2017 by the Institute of Health and other collaborators. And one of the basic principles to create this kind of framework was the fact that older adults can become a puzzle. Very good. And as they become a puzzle, it's hard to create interdisciplinary team approach to provide the care that they really want. So the framework that is called the 4Ms, and is part of the age-friendly health system, consists of these 4Ms that one of them is matters, what matters, medications, mind or mentation, and mobility. So we try to, as we take care of older adults, we try to have an overview, or we have to have a sense of all these 4 points. And if these 4 points at the end kind of become a congruent driver of patient care. Why, I know that many caregivers and people who work with older adults quickly can understand why, but for physicians sometimes and people who are becoming new in this is that we want to catch things that may adversely affect older adults. So in case of medications, of course, adverse drug events, mentation, trying to detect if the patient has cognitive impairment, like a type of dementia, like the one we are united here for, Alzheimer's disease. Do they have a component of depressive symptoms or depression, or they have something that we call delirium, which is that a sudden onset of confusion. And then in mobility, we just want to make sure we're doing everything we can to prevent injurious falls, any pressure sores or lack of, care of, and then even venous clots that can move around and promote a patient's deterioration and even death. And then in what matters is the fact that we want to make sure that we're giving the care that the older adult, our family member, our loved ones really want. Do they really want this care? Do they really want this amount of care that they're being provided? And do they want to be in the hospital? Do they want to be in the intensive care unit? Is there a way to avoid these things by addressing the 4Ms? So every time you're caregiving for older adults, especially if they have a disease like Alzheimer's disease, our main goal right now is to prevent a decline in their function. a decline in their function because they have an issue moving their body because they're weak, or an issue moving their bodies because their memory and the way the brain is working is not facilitating that function, like cooking or eating and things like that. So for us to be able to prevent that, it's good to have a sense of the mobility of the patient and address that mobility of the patient by, for example, making sure that at least for every meal we get them out of the bed to a chair to eat or walk to a place, and become a routine. That helps the older adult's brain dramatically to have a routine and have a sense of, this is what I'm going to do this morning, have breakfast, move around, sit here, read a newspaper. So create that routine. And then what I call about ambulation rounds is that every, 2 to 4 hours, think about if the patient can go around the house or any space that they may have, or, older adults can, with early Alzheimer's disease or any memory problem, can be super functional. So they can still go out and do their stuff and have fun. But trying to keep mobility, the less you use the muscle, the more muscle you will lose. So another important part of the mobility when you're caregiving for them is detecting that decline in function and then being able to act upon that perception that you're having. And is, for example, telling your primary care doctor or the provider that is caring with you the patient that he has decline in his mobility and now he's not able to transfer from the bed to the bathroom, or he doesn't want to walk around the neighborhood anymore. And there's so many things that could be affecting him and causing that it's good to address that as soon as you see it. And at times it is resolved by reviewing the medication that is part of the 4Ms, reviewing their mentation and mindset. Again, is depressive symptom, is an acute confusion, a sudden confusion that we can address, or maybe the mobility is related to aches and pains that we haven't detected, and then you kind of address those. The only way sometimes that we as providers that are caring for patients to know these things is that we work as a team and we give the space the caregiver needs to express what they're seeing on their loved ones or their patients that they're caring for. This is a quick one that just is a very old slide, but I like to keep it there just because it shows you how bad immobility can be as we age. There's a usual aging that we know of can happen, but people are very heterogeneous, so it varies depending on your genes, of the way you've been living your life, and things like that. But most of older adults, at one point, they're losing muscles. They have some instability of how they maintain the blood pressure, the way they breathe, the bone density start going down, and other things. And if you add to that immobility, you're just promoting these things to accelerate and get worse. And people, when they become more immobile, it's like a pathway to get into trouble, like going into a nursing home, getting into a hospital, or the caregiver being so burdened by the amount of care that needs to be provided that it is more difficult. So mobility is very important. Then pharmacotherapy as a caregiver is just keeping an eye on the medications, especially if they take too many of them. But these are the most important one that you have to ask your provider every time you're starting a new drug, if they're going to be interacting with each other, is it appropriate for his age, and why should we add this drug? What will be the benefit of it? And go carefully with that. And sometimes some providers may not feel comfortable discussing these things with you directly, even including myself. And sometimes we ask the help of a pharmacist. So if you don't feel comfortable with what the medications that your patient or loved one is taking, try to figure out if you can create another, you can add one person to the team besides your primary care or your provider, which is a pharmacist. And it doesn't have to be every time, but at least once or twice a year, reviewing all the medications, for checking for inappropriate choice of therapy, incorrect dosage, incorrect schedule, drug-to-drug interactions, duplications in therapy, or allergy and side effects. Again, mind or mentation is just trying to figure out, as you care for people, especially older adults, if they're developing worsening cognitive function, and that's something that it could be reversible because of delirium, or it's because they're becoming depressed by something, and or it's just worsening of the disease. So always trying to figure that out. And one of the thing is, and I put that the collaborative history is that the caregiver becomes the right person to tell the physician or the provider in general, the visiting nurse, anyone that is kind of helping you care for your loved one, that decline in function, and we rely on that. So that can trigger other things, and try to prevent further decline or worsening of that, or even improvement if possible. And what ADLs and IADLs is, and most probably that, and this could be repetitive, just ADLs is just activities of daily living, and then IADLs is the instrumental ones, which are more complex, right? The one that usually they lose first, the managing complex tasks, like using a complicated electrical device or a phone, or managing finances or driving and things like that. And then the ADLs is the one that are more when they become more frail and dependent on movement, like transferring from one place to the other, going to the bathroom and caring for themselves. This table is just a quick overview of confusion, a sudden confusion we would call delirium. That's our preferred name for it, which is an acute and subacute disturbance in cognition with evidence of an underlying medical etiology. So every medical etiology, medical reason, is a medical reason that has happened, that is multifactorial, and there's predisposing and precipitating factor working together, that have created this event. And it's important that when you detect those, that you get a provider with older adults experience or cognitive impairment diseases experience, so they can try to address delirium. So, but either way, if sometimes family member may become prone to get confused because of the disease, as they progresses, you need less precipitating factor interacting with the predisposing factor to become delirious. So I just giving you here some of the things that we do that we know prevent delirium. Even when it happens, it may decrease the days of delirium or the severity of delirium. And for example, for baseline cognitive impairment, it's just letting them know that they're in a safe place, where they are, what are they going to do, what is the next step in their routine, or keep them distracted with the orientation of the day, or creating an environment where they can do word games or puzzles if they want to. Trying to prevent sleep deprivation, trying to prevent immobilization, making sure they have their vision impairment and hearing impairment adaptive equipment in hand, or just kind of trying to improve on those, and making sure they're eating and drinking, and recognizing that early, because it can become a snowball. So as the 4Ms evolve with, as I said, what matters to them, their mentation, their medication, their mobility. As you can imagine, one caregiver and one provider may not be able to succeed in creating the best care possible for these older adults with Alzheimer's disease, for example. So, as I said, for medication, you can talk with pharmacy. For psychosocial assessment of the suppressive symptoms or care needs that are missing in your house, or you think you need, or programs out there in the community you may need, after speaking with the Alzheimer's Association, you may find that they're all, the social worker may direct you to Alzheimer's Association, and then you can find services that you were not aware of. The social worker can be very helpful in detecting some services out there in the community that may help care for the patient. Occupational therapy and physical therapy are very important. Occupational therapy not only detect a mobility restriction because of a trauma or a pain or things or injuries, but also occupational therapy tests for cognitive impairment and their lack of function because their memory or brain is not working perfectly. The case manager in planning your care usually could be a nurse case manager. It is very good in an office of a provider or any system that provide care for older adults to have a case manager, a certain amount for each case manager for patients, so they can provide and plan the care. And then, as we know, the nursing care and others, home services care that provide the direct care for the patient, like the home health aid and things like that, that needs to be added. And that works in consonance with the social worker and the case manager. If they will need a visiting nurse or they will need other services that are provided by the community. So again, this is the framework that I want you to be aware of, that every time you're caring for someone with which is an older adult, if you can have this in a piece of paper, baseline mobility, medication that the patient is taking, the fact that you reconcile those medication with your primary provider or even with a pharmacist, that you have a baseline mentation, and that baseline mentation may be by a screen like the mini cog or a formal other memory test, and you can detect that, and so you can follow over time, and then making sure you know what matters to the patient. So here again is just examples of these 4Ms, for example, in the community. Again, immobility is just describing to your primary provider or the caregiver to be aware of how the patient is moving in their house and if this is appropriate. Again, with medication, trying to address those medications. With the mind, you can screen for dementia and depression at least once a year, depending on your primary provider acceptance of this. And then trying to avoid delirium and trying to detect quickly if there's a change in mental status and who you're going to be calling for that. And then what matters is making a list of questions to ask at each visit, or who, what you want to do if something happens to you. Who will be the person making decisions for you if you're not able, or your caregiver or your loved one is not able to make that decision anymore. And making sure your provider is well aware and have copies of these feelings or your loved one's decisions on this regard. So as we evolve, we for sure are understanding that healthcare depends on a team effort. We cannot rely only on a provider or a physician or a nurse practitioner or anyone to be able to assess and treat every aspect of the 4Ms in older adults. It's very complicated. So one of the things in What Matters was, if you look at this one, is that the mom, the daughter of the mom, wanted to take care of the patient even though that she was working. She just wanted to be involved in every part of the care. And just because she cannot take care of her loved one 24/7, that doesn't mean that she cannot be there, right? She can coordinate. So if you look at the health, this cycle, the most important thing for this patient, that in this case is named Luis, it was that he wanted to be back home after his stroke. And so his primary care doctor was managing the overall care, everything that happened in the hospital. He received all that paperwork, reviewed everything with the patient, and created a plan, and instructed one of his nurses, nurse case manager, to coordinate this patient care. There were questions about medications, and the pharmacist was involved and answered all the questions about the new medicines that he needed to prevent maybe another stroke. A neurologist was treating Louis' stroke, and he pitched in on that. And then a psychologist was, after many persons that are victim of a stroke, they usually have changes in their mood. They have a psychologist involved. And then so forth and so on until you have this cycle of a team, and then they can get in and out as needed, depending on the patient's 4Ms at any specific time. So every clinic, every institution or company or that is caring for older adults should have a way to describe their team in every taking into consideration the 4Ms. So saying that, we're almost done, by the way, which is good, I think, for everyone. When persons, older adults, especially with memory problems, are admitted to the hospital, they can become a headache for the family and even for themselves. They get into a hospital and they get confused. So an example of these 4Ms, and I said we were using this at Kent Hospital when we created the ACE unit with the leadership of you know, the CEO of the program is of Care New England is a geriatrician. His name is James Finale. And then the chief of geriatrics, which Dr. Fulton, is a geriatrician that was also inclined to start an ACE unit. And we started an ACE unit using the framework, right? And what we did was a co-management. What that means is that you have the doctors that treat every acute or sudden medical issue, and then you add on top of that a geriatrician to oversee the care and create that team, right? And what we're trying to find was if we could prevent or improve things that happen with medications, with psychosocial issues, with immobility, and things like that. And what we found was that of those 75 admitted to our hospital from March to December 2019, their care improved to the point that they had less amount of days in the hospital. They had a decreased amount of falls in the hospital. They were able to be discharged home more frequently than to an institution, and the patient and family satisfaction went up. So that proves kind of that the fact that if you take care of older adults in an interdisciplinary approach, and we all start believing that we should care of patients as a team and involve everyone that is involved, to be redundant, in the care of the patient, is a pro. Is a good thing. And one of the key features is the close collaboration with the hospitalist, which is the doctor treating the sudden medical issues, and then creating that team to support him do his work. So these are just specific numbers that, we had around 1,800 subjects admitted to the hospital, and we took around 781 to our unit. And our population was a little bit older. The average age was 86. Most of our patients were white because we're in Warwick. But as you can see there, the length of stay was 3.9 days compared to 4.6 days. That's a big issue because that's like a half a day per patient. And then we were able to send to rehab in a lower rate, which means that we were able to prevent a decline inside the hospital. It usually happens when they're, have immobility or malnutrition and things like that. And then we were able to decrease the amount of readmissions to the hospital by almost 50%, from 16 to 7.2. So I think it's very helpful. I hope you understand that it could be very helpful for caregivers out there, for any institution, hospital, or primary care office to use the 4Ms to detect issues with the patient and find the right support and environment for care, create the care plan to improve their overall function so they can thrive and be independent or be easier to take care of by the caregiver. And then identify patients who may hesitate to say what matters most to them because they have a stigma of describing their feelings or describing that they have seen some issues with their function. And so if you address it this way, I think the rapport becomes quicker between the provider and the patient and the family and the caregiver. All this information and more information you can find in this website that I put there is at the Institute of Health. And then I just want to thank everyone that is caring for someone with cognitive impairment. I really appreciate my interactions with persons that know their loved ones or the patient they're being paid to care for very well. So if you have any questions, I'm here. But that concludes my talk.
Wonderful. Thank you so much, Julio. I do, listening to your presentation today, I keep wondering, and I talk to so many of our family caregivers through our helpline, each and every day. And, so many of them get frustrated by, the lack of time that their loved one has in a primary care practice, or with one of the specialists. And as a physician yourself, are there recommendations that you could make specific for the caregiver to say, what kind of conversations can they have with their primary physician to say, what, I need more time. These are primary care practices that may not follow the 4M model, but this is a well documented, model of care, but that they are not, getting that time, enough in their primary. Is there any kind of recommendations that you would make for the primary care, how to work with their physician better?
That's the most practical question. So that's why I ask first the caregiver to build that 4Ms by themselves, that paper. And in that paper, when they have mobility, mentation, medications, and what matters to them, kind of figure out if they're comfortable with that or they're concerned about that. Because that will save dramatic time where they go to the office. And it's a paper they can show, and you want to address that. And then expectation is very important. So when they make the schedule, it's good to tell the physician ahead of time of the office that you're going to go there to discuss the goals for your loved one's care. And sometimes I know that some physicians are still not up to speed with this. I hope they get there. But once you say that, that Medicare will reimburse for your extra time in addressing goals of care and goals of the patient care, because goals of care is not only saying that I don't want to be resuscitated, intubated, or escalate care to surgery, or it's also what's more important for the patient, which is I just want to stay home as much as I can. If I cannot stay home, I don't want to be treated for this. I prefer to let nature take its course. So that's very important to address early. And so it decreases suffering from families and patients. So I think having that list and then calling and make a schedule to say, I want to address my family member, my loved one plan of care. And I'm going to be specifically interested in discussing his medications and pick one or two, or pick all of them, depends. Your primary care may be so pleased by this. It may be the other way around. You think you will cause problem. He may be very happy to know, because that's how I get when I had a family member coming to me with already their concerns, so I can address that. I feel I'm doing the work. But if they go and I just say, oh, blood pressure control, diabetes, and then I let them go, I don't feel well.
Mm-hmm. And that's true. And I know for many of our families, medication, many of our loved ones, are on so many different medications. And, there seems to be lots of contraindications for medications for people living with dementia, and that they've become very sensitive and intolerant for certain medications. And we know that so many medications have side effects, and that can be very challenging for our family members to understand and to learn that. And and I see that you recommend talking to a pharmacist and recommending talking to the primary care physician. And so what are your recommendations around that? I mean,
so I think it's important that there is a free it's a free resource that you can look, but it's a resource that needs healthcare literacy, and a lot of our caregivers are very bright people. Some of them are nurses, are physicians, are home health aide already that have cared for older adults for years. So it's something called the Beers criteria, which is a list of medication that may be inappropriate for older adults. And if you detect those, as you see the list, it's good to mention it to your primary care. But again, I hate giving more work to our caregivers. They're already overworked and overburdened, in my opinion. So the best approach will be to send them to a pharmacist. And so in every clinic that I have worked, um, and I may be grateful for this, is you have to create that team. You find that pharmacist that is inclined to to look for these things in older adults. I have one here. I had one in I always had one. So your primary care may have that pharmacist if you haven't asked. And once you ask, they send you to see the pharmacist, and the pharmacist will review with you all the medications and how to titrate them out of your way, how to change them, what alternatives are there. Um, and I think that that's the only way to address that.
Can you repeat the that document that you just talked?
Very good. It's like the drink, but it's the last name of the physician who created the list. Beers. So it's BEERS. Beers criteria of possible inappropriate medications for older adults. And once those are detected, I think it's important that they address that. And for example, if the primary care do not want to change that medication that may be inappropriate, why is that? And that way you feel confident, because sometimes they are needed. So
yeah, I mean, absolutely. And again, I think, it's just so important that, we understand the medications that our loved ones are as being prescribed. I just heard recently that, I had a helpline caller saying that, their loved one was on a blood pressure medicine, and they had been taking it incorrectly for a year and a half. So, and we just don't know, how that might have affected their mental status. It could have increased a delirium state that we just don't know of. So, that's just really, really important.
Almost sometime up to 80% of older adults above 75 could be related to side effects to medications. So that's one of the biggest job here, and where I am right now is our interdisciplinary room where I meet with everyone. So here we detect those and try to change them as soon as I can and communicate with the outside world. But it's a very small population. So I know it's a big prevalence out there of these issues.
And another area that you were talking about, and physical therapy and occupational therapy is two areas that I think many of our families are just not aware of how that can support an individual living with dementia. And many times we'll have someone on our helpline talking and saying, my loved one has been falling more in the house, and I'm noticing that they're much weaker, in their walk, or having more difficulty, getting out of a chair. And, when I have, have you talked to the primary? I said, well, the primary physician has never brought it up. So,
that's a mistake. Yeah.
Can you address to our individuals that just, how physical therapy and occupational therapy, what some examples those two particular disciplines how they can support someone to improve X, Y, and Z?
Excellent question. So for people with cognitive impairment and their mobility restriction is more related to their memory problem, occupational therapist is the one that's going to help you the most, because it's the one who is going to be able to work with a patient even when they show no interest. Because as people get worse with their memory problem, they become apathetic, right? And people may even think they have depression, but it's just that their memory, they don't have any initiative to start anything. So the occupational therapist will be the one working with you and teaching you techniques to get them engaged and moving around, so they decline in function less over time, and giving you time to stay with them as long as you can at home or wherever you are. The physical therapist is more when they have a mobility restriction because of a weakness or an injury or a aches or a pain, and they're going to help you much more than occupational therapy. But occupational therapy encompasses a little bit more up to one point, because once they deal with the cognitive issues and the mobility restriction of the way they are eating, like let's say they forgot how to eat, sometimes you can recover some of that function if they just lost it. And so if occupational therapy come and detect what's the problem, why he's not eating well, you can gain with an occupational therapist. Once the issue becomes more, in a sense, lower extremity or mobility or balance, then that would be the physical therapist more than the occupational therapist. So that's very important to know. And so that's why it's good for caregiver to know the patient's baseline and inform the primary care right away of that declining function. It happens a lot in people with Parkinson's disease. They usually need intervention once a year to prevent a decline. I know this is an Alzheimer's Association meeting, but I want you to be aware of that. And what people sometimes don't know is that Medicare covers those services right away. Once the primary care validates that the patient has declining function, was able to eat, now not able to eat, and falling more often, we send visiting nurse services with home health aid and physical therapy and occupational therapy is covered. And then after a few weeks, they may go again. And then you call them again in 6 months if it happens again.
Excellent. Thank you. And in sort of this arena, I know many times, families begin to be concerned about the safety of their loved ones at home. And, so home, recommendations are home safety evaluation. So who would be doing that? So, and would, what would you suggest? Would a family caregiver talk to their primary care physician about that? And who would come into the house to do something like that?
Yeah, it is also the primary care. And it depends on the company you select after your call. The referral is made, and then you select the company you want to provide those services of home safety evaluation. And what that means that somebody will go there. It could be a visiting nurse or an occupational therapist or a social worker, and then go through things that can promote falls or safety issues or people escaping from the house and things like that, and give you recommendations. And after those things are brought up, is also will be covered, some of them by Medicare. Those changes in your house to make them more safe for your loved one or the person you're caregiving for. But it depends. I wouldn't dare say which one is my preferred person to do the home safety. It depends on the company. But where I trained was usually the occupational therapist doing the home safety eval, and always going with a visiting nurse. So usually the visiting nurse go first and detect medications, patient's morbidity, meaning diseases that he has, the medication, then the psychosocial environment. And then that visiting nurse then will say, I need an occupational therapy and a social worker and things like that. And that's how you open in Pandora box. Once you're doing that, you're doing your job, because then that should open up a door of care for you that you may not be aware of.
And you mentioned, ultimately, with the the results from the work that you have been doing at Cotton Hospital, with the 4Ms and the work that you've been able to reduce the number of, hospital stays, first of all, but then also reduce the number of readmissions within, I think you said 30 days. So, so it appears that the framework of the 4Ms can be extremely valuable to really, support that individual. Because I know when, an individual tends to be hospitalized, their functioning declines many times because of it's really a catastrophic event for that individual living with dementia, going into, an acute setting where they're, become very disoriented, and just the stress of going into that environment.
That's exactly right. Yeah, that's exactly right. So what we try to prevent when they come here is everything that could make them decline in function, perpetuating that medication that may be inappropriate, promoting an environment where they can get more confused and agitated, providing them with the support for the family to be here longer periods of time or even sleep here. So there's a lot of things that we do that are a little bit different. Now, it's our opinion that at one point the whole hospital will become like that, but we need the resources are still kind of building up. And I am a believer that this framework may be even more impactful in the outpatient, in primary care clinics, and for caregivers to utilize as a framework to improve their loved ones' care.
Mm-hmm. Many times, we talk to families about, how to support the staff if an individual unfortunately does have to go into the hospital. And because our family members sometimes know that patient going into the hospital. So what recommendations might you give to a family member if they are going to be having to care for have to see that their loved one goes into the hospital? What kind of recommendations would you make to our to our family members to support the team at the hospital?
Make yourself very available. Give a good phone. Tell everyone that you interact with that you want to be informed of any changes in medications or change in where the patient is. Let's say the patient, you left them in the emergency department waiting for a bedroom. You let them know that you want to get called when he's being moved to a bedroom, and try to be there in every transition if you care, if you can, because familiarity is very important. Try to make sure that when the patient comes, the hearing aids and the adaptive device for vision are with them and safe, and that you make sure that they don't lose them. um, and remember when was the last time they moved their bowel and they were urinating okay. Remember if they were eating or not okay. Have they been losing weight? And be prompt to answer those questions quickly. And if you already did your 4Ms, bring those. The medication, what matters to him. He doesn't want to be resuscitated. He doesn't want to be kept alive in a, thing and whatever. And then you go from there. But hospital environment, there's no doubt, is you only need it. You only use it when you really need it. And as we evolve, there will be more units like the one we have here in other hospital in the state, and maybe every unit will become, because, for example, I heard a number very recently, like, for example, in the VA hospital here in Providence, 70% of the people utilizing their services are above 65. So you have to have special units for older adults there. Yeah.
Absolutely.
Yeah.
Any suggestions around, we know that many times, personal items or can be comforting when one of our loved ones go into a hospital or go into an acute setting for, short or long term. Any suggestions around that? And, with the training that is being done with staff, are the staff being trained in interacting with an individual, and then that too, working with the family to support them, because this is a stressful time for them as well.
It is. So some of the training so increasing sensitivity to families' needs is very important in our unit. Keep them informed, and then getting them involved in the patient care saves time, saves money, improve patient satisfaction. So bringing if the routine was newspaper or reading a certain type of books, keep them those here. A specific picture. I had one patient that was very adamant of having the picture of his grandchildren. He didn't have cognitive impairment, but that made his time here in the hospital more pleasant, seeing the pictures of his grandchildren there. So yes, bring those. The more, the ones that they really use a lot. Sometimes it's just they want to always have a pen for some reasons. So I cannot write anything. So we try to do that. Either way, we have a good amount of things here in the hospital to give them to keep them not entertained, but you know what I mean, more distracted, and not focusing only on the fact that they're in the hospital and that they're sick. And our nurses and our CNAs and everyone involved is very sensitive to that.
Actually, I mean, we call that person-centered care. It's really what we're talking about.
Exactly.
Yeah.
Correct.
Absolutely. Let me see if we have any questions from our audience. Let me just kind of peek and see here. So it was just nice that one of our registrants, she put the information in there about the Bears criteria. So Kathleen, thank you so much for adding that. And I will see if I can find that reference form and send that to individuals after this afternoon when
There's a lot of good information in that website, yes, of the Institute of Health, yes.
Yeah, absolutely. Thank you. Is there any questions from anybody here in the audience that would like to ask Julio before we sign off? Let's see. It seems many times that we almost want to say that if we can provide the really supportive care to the individual at home, then we can hopefully prevent those catastrophic experiences for them to go into a hospital setting. So just being able to really validate and support know exactly where an individual is within their baseline of where they are in where they are in that disease progression, and then truly being mindful and observant to seeing if there's any particular type of any changes, and completely getting in touch with the primary care physician if we're seeing any changes, and our caregivers need to be on top of that.
Yes, and as you may be aware, the hospital at home program that was approved already by Medicare is attaching community health services, hospital level care to the patient's home, attached to the community hospital. So those are going to evolve and grow because they have a funding for that. And usually when there's economical incentives, usually they grow a little bit faster. So the goal is to have around 5% of the most complicated older adults around a community health center being taken care of at home if meet the criteria.
So here's a question. Kathy's like, how do you find a primary physician to help you?
Well, so now you're asking the constraints of healthcare. So that's one of our constraints of healthcare, is the fact that we may not have, or we may have maybe enough, but we don't have them specifically trained to be able to care for older adults, maybe. Or we just don't have enough. I don't know. I will say I don't know about that. But how do you find them? It is challenging. That I cannot say anything more than that. It was challenging for me when I moved from Connecticut here to find my primary care physician.
Many times
I have him for 8 years, and I wouldn't change him even, for you just want to find that primary care that you can speak to, and always be respectful. They don't have enough time. Usually they're giving 15 minutes to 30 minutes, and that passes pretty quickly. So being respectful, I'm respectful of his time, but I go with a list of things because I get sick too. But no, it's challenging. Yeah.
I think a lot of times too, one of the first places that, we encourage people to go to their insurance company, and their health insurance, and, ask questions. It's always, I think it's always be in your, when you're in your primary care physician's office waiting for that appointment, talk to your patients, and and have conversations with, what do you think of, who do you use, ask friends and family, who their primary physicians are, and ask their opinions about them. Who's going to be who do they recommend? I think a lot of times we can get some really good recommendations just from the people around us that we know.
Yeah, that's very important. Yes, if now that the question is at that point is, any family member that has a primary care, try to ask them if they like them, and try to see if they can introduce you to that primary care. That's a great point. That's a good way to go in, because if they know you're the sister of this patient, and then it's easier for them to connect things and say, yeah, I'm not taking any patient, but I'll take you because you're the sister. That happens all the time. Because I know sometimes they're capped and things like that. But yes, calling your insurance is important, and also calling hotlines for Lifespan and Care New England. They have, and you said you want a primary care, they will they will try to find you one. And I think Care New England is looking at trying to even cut down on the amount of weeks you have to wait to see one.
Absolutely. So I think one of our families that are here, and they just like to clarify again the difference between what ADL is and IADLs are.
Oh, perfect. Yeah, the instrumental activity of daily living is those that usually people with cognitive impairment will lose first because they're more complex. So finances, managing their finances, managing their own medications, using a complex electrical device like even a phone, and for example, providing or cooking will be difficult. Because it's mixing things. That recipe they was wonderful when they were younger. Now they're having trouble making them again. So activities of daily living will be just eating, drinking, going to the bathroom, and providing the care they need to clean themselves and things like that, and go from the bed to a chair. So just the activities you need to survive will be the activities of daily living. And it could be sometime instrumental. If you think about it, instrumental is those that takes 3 steps to perform. Yeah. And then eating and transferring from bed to chair is something more easier. And then remember that these things could be affected by mobility restriction because of something in their body, or because their memory is not working well, right? They lose the ability to perform certain tasks because the brain cannot sequence, start, or progress the event they want to perform. So it's good to know that also. And occupational therapy and physical therapy can detect which one is because of their memory or which one is because of the weakness in their muscles or pain in one knee.
Okay, thank you.
No problem.
And Amy Rodriguez just says, is the goal to keep them home because of the confusion, mentality issues, or costs of in a facility care, or both? I worry about the isolation at home.
Yeah, very good question. So no, we know and that most of our older adults don't want to be in the hospital. If like this morning, maybe 90% of them, we have 20 beds, they want to go home. They don't know why, but they just want to get out of here. So one of the and then over time we have noticed that people who are able to stay at home and be cared at home for the same degree of sickness, they do better at home than if they come to the hospital. So the reason why we want to care a certain amount of patients with certain characteristics at home who are old is because they do better there. Now, it also, when you create an environment, when you bring a patient that will do better at home and you bring it to a hospital, the cost is just amazingly high, because then not only they doing worse, but now you're treating the complications of the disease and the complications of the treatment that you gave that was inappropriate for an older adults in the hospital. So it is a win-win situation for us, the geriatrician, that finally people are understanding why a geriatrician, we're always prone to try to treat people in their own environment, if possible. It's a familiar space. They get less confused. They have all the things they need next to them. They don't have one person next to them, maybe with confusion, yelling all night, and then they cannot sleep. There are a lot of things that could happen.
So, but in those situations where an individual has to be hospitalized, then
they do better in the hospital.
So with this forum framework and creating a dementia-friendly, environment for the individual,
that's a good point that people understand. So some diseases and sudden medical issue needs to be treated in the hospital. And then there's certain characteristics and certain issues that the patient may be treated at home. And that's why there will be a screening for hospital at home. Once they're in the hospital, it's just creating that environment that is safer for them using the 4Ms, as you said, Ms. Murphy. Right.
Many times too, and I just, we have just a couple of more minutes, but I just want to address this. Has, with the work that you've been doing at Kent in the framework, was some of the hospitalizations due to, dementia-related behaviors? And if, is it possible that some of those hospitalizations potentially have been, that we may have been able to, not the hospitalization might not have happened if something occurred differently in the home environment.
Correct. It's what I call older adults do well in the right environment. Sometimes, if they're at home and they're deteriorating in their memory and function, but the family and the caregiver, it's hard for them to notice those things, are not well guided. They will try to keep them there, thinking that they will do worse in a different environment, to the point that they cannot uh, care for them because of their behavior. It's a very uncomfortable behavior, and they're getting worse. The primary care, or even a geriatrician, or a geriatric psychiatry, or anyone having trying to address the patient issue, but still not doing well at home and getting very confused. Sometimes they end up in the hospital, uh, and with a fall or just worsening behavior that the family even gets scared. And then it's our job to detect that and try to find the right environment for that patient for the moment, and try to detect reversible causes, give them therapy, maybe send them to a rehab place for a week or 2 or 3, and then see if they can go back home, or may need to go to a different level of care, like an assisted living with a memory unit or long-term care. But yes, totally agree with that. A lot of people come here because we weren't able to address the needs in the 4Ms kind of way in their own house.
I know for many people, the Alzheimer's Association actually has two educational programs that can be viewed online. We offer the program in our communities in person and also virtually, and they're both specifically on how to, we educate our family members how to support someone who's experiencing any kind of dementia-related behaviors, and we educate families about why some of these behaviors may be occurring, how the environment or even what you're doing as a loved one may be precipitating or increasing those behaviors in the environment. We also educate families on how to communicate with their loved ones more effectively, so that we can reduce anxiety, improve just that individual's calmness. So I encourage anyone to reach out to our helpline at 1-800-272-3900 to ask where those educational programs are occurring in the community. Anyone can actually go on to the Alzheimer's Association's community resource finder at www.communityresourcefinder.org. And you can actually just look up the programs that are in your community and find out when they're taking place. Again, I think education is extremely powerful to educate our families so that they can understand why these behaviors may be occurring with their loved ones. It could be fatigue, it could be malnourishment, it could be dehydration, it could be something that's affecting them in the environment that could be exacerbating some of these behaviors, which can be extremely frustrating for our loved ones on a day-to-day basis. So, and that can potentially help when we don't have to get to that point where, we're needing to might having to, call, emergency services, or even, sending their loved ones to a hospital because they're so overwhelmed with those particular behaviors. So,
Yep.
yeah. So I want to thank you, Julio, so much for being with us this afternoon. It doesn't look like there's any other questions, but I can tell you that many of our participants have said thank you. The information has been really, really helpful. It's a different way for a framework for them to be considering when thinking about being proactive with their care. So, do you have any particular, sheets or worksheets that you can provide to me by email so that I could send out to our participants that they can have?
You know what? I will, and you may expect it in a few minutes.
Okay, great. Absolutely.
And it's exactly for caregivers, and I think they will like it. They will use it.
Great. Thank you so much. So this will just end this portion of the conference.